and welcome back to Health Watch. Today we're going to be talking about some newer techniques in the treatment of low back pain. And as our guest, we have Dr. Mark Oliveri, orthopedic consultant. Welcome to the show.
Nice to be here.
Mark, you've been on our show a couple times talking about, particularly about back pain, and it's always impressive to me as what percentage of the population at some point in their life develops low back pain. I have it, you have it. If you've ever played golf, you've had it.
Right.
So it's a very common complaint, and we kind of let's walk through how, your approach to even diagnosing these people and working them up as an orthopod.
Yeah, well, back pain, as you said, Vince, is actually the number one disease entity that actually keep people out of work. Okay, so luckily, the majority of back pain that people have is self-limiting. That is, they'll have it, and over a period of time, even without any significant treatment, it'll resolve on its own. And that's why we as physicians have to be knowledgeable of that fact and supportive of that fact. There is a subset of people though where the back pain becomes chronic, and in those subset of people, there are some people who actually could benefit from some more aggressive type treatments. But the initial treatment most times for back pain, and if it's just back pain, is usually rest, anti-inflammatory medication, sometimes physical therapy. And then if those sorts of treatments don't work, after a period of about 4 weeks, then we get into more aggressive imaging studies to make sure that there's nothing significant going on why somebody would have back pain. And those imaging studies would be something like a CAT scan or an MRI or a bone scan.
Okay. Well, let's just walk back to a little bit about the common presentation guys at work, and he lifts the box, and next thing you know he's laid over. Is it more muscular spasm that's producing the pain, or is it actually impinging the nerve, like we all kind of think about?
Most times, a significant portion of the time, it's a muscular strain. If somebody comes in and says, "Oh, my back hurts," and they don't have any radiating pain down their leg, more than likely it's a muscular strain or sprain. Strain, muscle, sprain is the little ligaments around the low back area can get stretched. So the majority of times it's a muscular skeletal issue.
Having had that, it's amazing how those spasms can really lay you up. I mean,
it can be very debilitating.
Yeah,
sure.
It really. And it's interesting. You mentioned rest. I've seen some articles that talked about that we used to put people at bed rest for this thing, and actually found that they did worse than if you got them up and moving around and got them to rehab.
That's exactly correct. If you get a short period of rest, but actually that if you go beyond 24 hours or 36 hours in bed, then the bed rest can become deleterious or worse for you, because that bed rest will actually cause like muscle atrophy or even provoke something like a blood clot in your leg. So That's why it's better for you to be out of bed and mobile if you can. Yeah,
much as you can. Talk to me about, we have a lot of anti-inflammatory drugs, so the assumption is that you get, the ibuprofen and those types of drugs are advantageous to use?
Yeah, yes, they are. If you don't have any concomitant or other medical issues, significant heart disease, or you're not on blood thinners, stomach issues, then the anti-inflammatories can be very helpful to reduce the amount of pain you have. That's one technique we use, is to place someone on a short-term anti-inflammatory medication, and Advil or Aleve or Naprosyn and some of the other prescriptive medications can be very helpful to reduce the inflammation. And also, sometimes when someone has a really acute onset of back pain, we also occasionally use steroids. Not steroids where you're going to get like
not pump up steroids. Yeah.
But there's another class of steroids, cortisone, which you can take orally or get a shot, and that can reduce fairly significantly any inflammation that you have. And we use that also at times.
Yeah, we're going to talk about other uses of steroids, but sure. I was aware of that. How about the new, some of the new, you talked about muscle spasms, which are part of the process, I guess, but some of the antispasmodics now, the Flexerol type drugs that we used to use in the past, and the main thing, put you to sleep more than anything else.
Sure, they can be helpful, but I personally don't like to have patients take them during the day. There actually are some newer, because they can be very sedating.
Yeah.
So if people are going to take a antispasm medication, I'd like to have them take it during the evening. And actually, there's a newer one out now, like Flexeril or cyclobenzaprine. Typically works for about 6 hours. There's actually a newer antispasmodic that actually works for almost 8 to 10 hours, and we use that one at nighttime, and that can be very helpful for back spasm and also help people sleep if they do have a little bit of back pain, and prevents them from sleeping.
Right. Physical therapy?
Yep.
How do you get
Yep.
them involved and when?
Yeah. Physical therapy can be very helpful to reduce the amount of back pain that someone has. You know, some direct physical therapy techniques like massage, TENS units, and then active therapy, stretching, range of motion. And actually, the most important thing about the therapy is that once somebody gets rid of their back pain, if me or the therapist can identify, you know, what caused this, then the therapist can teach the patient how to do a home-based exercise program to prevent a recurrence of the incident that occurred.
Yeah.
And that's actually the most helpful aspect of it. But again, a lot of times in our society, people don't follow, like, you know, continue exercising, you know, lose weight, you know, don't smoke, those sorts of things. Those really help prevent back pain more than anything else. But if we can sort of support the patient and tell them that, that's our job.
Yeah, and I think to that point, you know, really what the patient can do for themselves going forward, I think, because, you might want to speak to that, but if you've had a back problem, unfortunately, it's usually not a one-time event. You're more likely to have it. There are things you can do, exercise and stretching, that can help patients avoid those kind of things.
Yeah, I think that if you can be, so it's a couple of different things that really help. If you can be as fit as possible, you know, and being fit doesn't mean you have to be, you know, super muscular, but just maybe aerobically fit. If you walk 20 minutes every day, you know, get your heart rate up 20 minutes a day, that'll help. Number 2 is smoking. I think actually the smoking is the #1 thing I see that can be prevented, that actually can have a significant bad outcome for your back.
Really, that's amazing.
Yeah, if you start,
we blame smoking for a lot of things. I wasn't aware of
it's
that.
it's actually it's been shown several times that the smoking will advance or occur more quickly degenerative disc disease, disc disease in the low back and the neck.
Well, yeah. That's another reason not to smoke.
Yeah. So, but basically, being fit and reducing smoking will be the best things you can do to help prevent, like, recurrent back pain episodes.
I think we're going to take a break, but when we come back, we're going to talk about those issues. I think the thing I heard from you I thought was important before we went on was how many times you see patients, in fact, that you don't recommend surgery. And
Correct.
you being an orthopedic surgeon, but and particularly one that does primarily back work, but so many times these messages are successful, and patients need to know, gee, if I do this, I'll be okay. I don't need the surgical, or for that matter, need a whole lot of diagnostic tests.
Correct.
So we're going to come back and talk about the ones that in fact do, and we'll be right back after this message.